can tell you that 60% of my patients are overweight. And so what do you do for those patients?
Yeah.
How do you help them?
How do you start? Yeah.
Right. So when you're doing a weight loss program, many of the people that have seen me have already tried the weight loss diets, like Weight Watchers, have tried the Octavia, have tried.
What about the one where you don't eat any sugar and carbs?
Oh, the paleo.
Yeah.
Yeah, paleo. They've tried all of that.
Yeah.
But ultimately, what happens is you lose the weight, and then your appetite still stays the same. And the big thing about losing weight is being able to control insulin.
Okay. So that's the sugar change, right?
So insulin is basically the hormone that helps sugar. It basically helps convert sugar into fat. And so you can do the intermittent fasting, where what you do is you control the amount of insulin secretion. So if you only eat a certain number of hours in a day, your insulin isn't always on.
Working, yeah. That's because I was going to say, when you're telling me about the police officer, because I fasted for the first time in my life in February of last year, and I lost like 15 pounds, and I was already skinny-ish like this, right? But I was just like a little bit warmer, that's what I would be calling it, right? Because I was just a little fluffier, and I was only eating once a day, but I was eating more home-cooked meals than usual because I would eat out, but I was still eating the same kinds of foods, right? And so I wasn't working out any more or less, but it was because I was only eating once a day at noon, and that's how I lost all that weight.
Yeah, so that's a form of intermittent fasting.
Yeah.
So there's different hours for intermittent fasting, like you can do 6 hours, you can do 8 hours, you can do 12 hours. Obviously, the longer the time, the more the weight gain, right? So if you're allowing yourself to eat for 12 hours, then you're going to gain more weight.
Okay, the hours that you're working to eat. Okay,
yes,
gotcha.
yes. So if your intermittent fasting period is greater, then you'll lose more weight. Okay. You can adjust it so that, let's say you eat 6 hours a day, or you can eat 4 hours a day, you can eat 8 hours a day.
Like the windows of where you eat.
Yeah. Right, but you keep it the same.
Yeah. Oh, that's the consistency also matters.
Yeah, consistency of intermittent fasting. Yeah, because if you're going to do it in the morning, okay, well, tomorrow you want to eat in the afternoon, then you're changing the hormone and how it shows up in your body. Oh. So if you do intermittent fasting, let's say I do intermittent fasting. Okay. And I eat between 3 and 7. Yeah. Every day. Yeah. And I have lost weight. Oh. But the way the medication works is it controls your appetite. Yeah. It reduces gastric motility so that when you eat, it slows down your
like the breakdown of the food?
It just slows down how much you can take in. So like you feel full faster.
Oh, so where does Ozempic fall in that?
It's the semaglutide.
Oh, it's a type of?
Yeah.
So
Ozempic,
what are the other types?
Zepbound, Mounjaro.
Oh, so because you're saying the Robe one is oral, but the Ozempic, this injections, right?
Yes, and those tend to work better.
Because
it's once a week. It's once a week, so easier. Small injection, done, as opposed to taking a pill every day. Tirzepatide targets 2 hormones, when Ozempic only targets 1. And you can't take it like if you have a history of thyroid cancer, if you have stomach or intestinal issues. Look at how much it is a month. $1,000 a month. Wow. I don't charge that much though.
Okay, so the gastric bypass, these people can't use Ozempic and stuff? Or they
So for the gastric bypass, I would not recommend using the semaglutide or Mounjaro. Only because if they already have had something mechanical to their gut, so on those people I would probably have them, so not completely no, but you want to ask their gastroenterologist or their endocrinologist if they think it's okay.
Okay.
Those patients are not, like there are people that it's okay to prescribe the semaglutide and the Mounjaro, and there are people that you don't. Yeah. So one is you don't prescribe it to people that have a history of thyroid cancer. 2, you don't prescribe it to people that have like any history of nausea or vomiting or like gastric issues. Yeah. People that have the gastroparesis.
They have to come from a healthy gut.
They need to have at least somewhat of a healthy gut in order to be able to be prescribed medication.
That makes sense.
And then Kelly Clarkson is on Mounjaro.
Who's Kelly Clarkson? Oh, from American Idol?
Yeah, she's on Mounjaro. She's on the tirzepatide, and she's lost a lot of weight. And Oprah Winfrey is on semaglutide.
How come they can't lose weight?
It's hard because when you're a celebrity and you're surrounded by really fancy food, and you know, you're constantly exposed to really good food and alcohol and wine, you're gonna tend to indulge more.
Yeah.
And usually, but they work all day, they don't eat all day, then they go home and they binge eat.
Yeah. Okay. Yeah, because I hear a lot of people that don't eat, but they're so big, and I'm like, how does that make sense?
So if you're not eating all day, basically your body is starving.
Yeah. Right.
Okay.
That can't be healthy either.
And then when you go home, you binge eat, which means you eat an insane amount of food.
Right.
That's all going to convert into fat. Again, it's an insulin-driven process. So if you're used to like, okay, I have to have my coffee, I have to have breakfast.
Yeah.
Insulin is on.
Yeah.
I have to have lunch.
Yeah.
And I need to drink a soda. Insulin is on.
Yeah.
You eat dinner. So your insulin doesn't get a break all day long.
So
and
the
so
people
then
that are like snackers, they're the worst type?
Yeah, because your insulin
No
is
break.
on all day long. So, but if you're on medication, you can go home and eat, but you're going to feel full a lot sooner.
Okay.
So what this does is it kind of helps control your urges to eat, which helps regulate your insulin.
Okay.
And so as that happens, then you lose weight, right?
Yeah.
Because you're not eating as much.
Yeah.
And then it controls your insulin. So people that are diabetic will notice that their hemoglobin A1C goes down.
Okay.
So it's like
What's
killing
that?
two birds with one stone.
What's
Hemoglobin A1C is it's the blood marker that we follow to see if a person's diabetes is under control.
Okay. So if somebody has diabetes,
This
But
is
they
a
only-
great drug for them.
right. Would it have to be type 2 diabetes then? Or
Yes.
would it be effective with somebody with type 1 diabetes?
That's a great question, actually. It should theoretically be both. But with type 1, they still need to be on insulin.
Would this be a first step or a last step, right? Because wouldn't
So first,
medicine-
obviously the first step is you want to,
eat less, healthier?
just eat healthier, eat
Yeah.
less, exercise more.
Right.
But in this day and age, people don't have time to
That's not
exercise.
The priority. Yeah.
Well, not that it's not a priority, they don't have time. With the economy the way it is, people are working harder, trying to keep their jobs. And the issue with, like now, you go to your physician and you say, well, I want you to start me on the Ozempic or the Mounjaro or the semaglutide or the tirzepatide. And if you're not diabetic, they won't give it to you. So you could be morbidly obese, have all these health
You
concerns.
can be morbidly obese and not diabetic?
Yes, those two can coexist. And those are the people that really want to lose weight, but they can't. I'm a spine doctor.
Yeah.
I take care of people's back pain and knee pain.
Yeah.
They can't walk
Yeah.
to exercise because of their pain.
Okay.
So what solution do I have to give them? I can offer them semaglutide or tirzepatide.
I see.
It's a great option for them. And then they start to lose weight. And as they start to lose weight, their pain reduces. And they can start to be a little bit more active so that I can help them, by treating their pain.
Oh, I see.
Again, this medication is to help control or help people control their appetite that have had a long-standing inability to control their appetite.
Okay.
And inability to control those urges.
Yeah.
By doing this, you're helping them lose weight, and then they feel more confident, and then they want to walk more.
Yeah.
And again, this is in those instances where people don't have pain.
Yeah.
They feel better about themselves. Everybody feels better.
Yeah.
They start to lose weight. Their health gets better. The risk for cardiovascular death goes down. They want to go shopping and buy new clothes. That's better for the economy.
Yeah.
So it's a win-win for everybody.
Is this like a self-control issue though?
It can be, sure, of course. Food is an addiction.
Yeah.
Eating is an addiction. It's a very real disease.
Yeah.
And the semaglutide and the tirzepatide are being used to fight this addiction. And they're actually saying that obesity, for the first time, the obesity pandemic is on the decrease because of tirzepatide and semaglutide.
So when as a doctor would you tell somebody to stop taking the medicine and then convert to more natural means? Is that
That's a great question. So that obviously depends on like the doctor-patient relationship, right? So if the patient has a certain goal and it's within reason, that's where I talk to my patient and we come up with certain goals.
Yeah.
If they reach that goal, then we taper them off the medication.
Okay.
And by then the intermittent fasting for them is easier.
Okay.
And so they start working on the intermittent fasting. Maybe they work with a slightly greater hour interval first.
Okay.
And then they can reduce it or adjust based on their personal life.
Well, for somebody like, I've seen a lot of people do paleo, and I think that has really negative side effects because you cut everything out, and then as soon as you go back, you blow up because you didn't learn any discipline, right? You didn't learn to manage your self-control. You're just removing until you can't tolerate that. It's not a real lifestyle choice. Did you see people having like the same adverse effect with like Ozempic and the one that Oprah's on?
So yes, so I've had patients where they're on the medication and for various reasons they want to stop it. And so I suggest that we taper off. I've had one instance where a patient said, nope, I don't want to do it anymore. And they just stopped cold turkey against my advice. But they were on a lower dose, so that was okay. If they were on a higher dose, I would have insisted that we taper down, but they were on the lowest dose. And their appetite increased. And they had a 10-pound weight gain in a month.
Oh, wow. Okay.
So it's just, and that person was on a low dose, was just getting started, like, 3 or 4 months. They reached their target weight.
Yeah.
And they're like, I'm done.
Okay.
But in those instances, you have to kind of learn the behavior. I can't teach somebody behavior.
Right.
The medication helps you kind of adjust your diet, adjust your eating, kind of interval where your insulin can be better controlled. And then it's a matter of how you teach yourself.
Yeah, exactly.
But medication does help. And there are people that just stay on it forever. They don't want to come off it because they like the feeling of not wanting to eat.
Okay.
Yeah. You asked the question, could there be any downside to being on the medication long term? For right now, I think because the drugs are so new, it's hard to make that determination. But there are patients that don't want to come off it.
Yeah.
They like that feeling of not feeling hungry and being able to control their urges and just feel great, just physically, emotionally, mentally. Yeah.
So something that I was thinking about when we were talking about this was like, this being like a replacement of cigarettes, right? Because mentally, it's kind of the same idea, right? Like, it's an addiction, and you're not feeling hungry. People curb their appetite, taking a cigarette all the time.
Right.
And so it's just like, is there I don't know if we know this yet, but like, is there maybe like a similar ingredient in both of them that it's there, right? Because if you think about Big Pharma as is, they do that to keep business, right? That's just the way Big Pharma regulates and operates. So it's just interesting to see, like, are we changing people's addictions from one thing to another rather than treating addiction, right? Because that's what we see a lot, right? We started with the addiction to food. Now we're addicting to the medicine that lowers the appetite.
That's a very good point, yes.
Yeah, like, because people are addicted to caffeine, not realizing that they're having, like, secondhand side effects like low appetite.
I think my opinion on that is there are certain addictions that are acceptable.
Right.
And are okay to have. Yeah. And if you think that
it's also society-based.
Right. Yeah. If you think the semaglutide and tirzepatide is an addiction because you want to look, feel, and overall be healthy, I'm okay with that.
Right.
If you're telling me that you want to continue to smoke cigarettes or, have some other form of addiction that's going to have a poor outcome on your body overall and overall long-term health, I'm not okay with that. Okay. And anything where an addiction is used to hurt someone or hurt yourself, I'm not a proponent of. But tirzepatide and semaglutide have had such positive results, that addiction for me is okay.
Okay. That's really interesting though, don't you think?
Yeah, yes it is. We're shifting.
Yeah. But you're definitely right about addictions being, what was the word that she used? Like, socially acceptable. Yes. Some of them being more than others.
Yes.
Like, there are tons of people that are addicted to working out. Runners, like the runner's high.
Yes.
It's absolutely an addiction.
Yes.
But it's socially acceptable because it's positive.
Yes.
Yeah.
And it's not causing any detriment.
Right. It's to your knees and like those are that happen anyways. That happen anyways.
If anybody wants to consider the semaglutide or tirzepatide, just call and I'll do the consult. I do get a weight and a measurement. Yeah. And then
why do people not like that part?
They hate that part.
Really?
Yes, because
it's like facing themselves in the mirror.
Yeah, my scale actually talks to you.
Really?
Yeah, so it actually, you weigh on it. It tells you how much you weigh because people don't want to look.
Oh, what?
And so it tells you how much you weigh, and that way they know. But you don't use that to discourage you. You use that to encourage you. Yeah. And just know that it won't be there the next time you step on the scale.
Oh, okay. That's interesting. I want to try.
Yeah, sure. Go on. I'll show you.
Right, okay. Let's try.
Body weight is 151.4 pounds.
Okay, you're actually pretty good. You should be.
BMI.
So
is that what that is, right?
Yeah. So you should be between 19 and 24,
you're at like 22.
Okay.
And you should be between 125 and 158. So you're perfect
158.
for your weight. 20. Yeah, your BMI is actually 24.9.
Is that good or bad?
It's good. You're actually
At the very beginning.
No.
I think you said mine was 24.
19. It should be 19 to 25.
Oh, okay.
Yeah, but anyway, you're good. You're at ideal body weight.
Yeah.
People are losing weight.
That's awesome.
Yeah.
I like that. That's really cool.
Yeah, well, that's cool. Well, thank you.
Yeah. Thank you.
We'll see
Glad
what
you do
you-
some really cool work. Where can they find you?
I'm at Proto Aesthetics, Alexander Deputy Salon. Make an appointment today.
Bye.
Bye.